Hi, I'm Dr. Mila Brujic, and today we're joined with Dr. Karen DeLoss on the OI show, where we're going to be getting the down low on GSLS. Dr. Karen DeLoss, thank you for joining us today. So, Karen, tell the audience a little bit about yourself, a little bit about your background.
Hey everyone. My name is Dr. Karen DeLoss. I'm at the University of Michigan Kellogg Eye Center Department of Ophthalmology. Been there for about 14 years, and I'm specialized in specialty contact lenses, dry eye, and all other things. I'm involved in a number of organizations, including the vice chair of Global Specialty Lens Symposium. I'm also now the vice chair of the AOA CLCS section, among many other things. So I'm happy to be here today. Thanks for having me.
Karen, a little bit about your educational history. I know that you're not just, well, not just, you're an optometrist, so you graduated with your doctor of optometry, but you have a little bit of extra training, and tell us a little bit about that as well, too.
Yeah, absolutely. So I graduated from Illinois College of Optometry just a few minutes ago. And then After that, I went on to the University of Houston College of Optometry, where I worked with Jan Bergmanson as his cornea and contact lens fellow. And then beyond that, I also did a clinical fellowship at Boston Foundation for Sight, where I did additional training on scleral lens fitting for pros. So I've had a little extra time to learn too much sometimes, I think it is.
Well, it's fantastic because it actually puts us in the right framework of what we're going to be talking about here, which is GSLS, which is kind of the acronym that everybody now knows that stands for Global Specialty Lens Symposium. So you are on the board for GSLS. Tell us a little bit about, first and foremost, your role on with GSLS and a little bit more of a deeper dive on what somebody could expect education-wise from the Global Specialty Lens Symposium.
I've been the vice chair of the program committee for GSLS for several years now, too many to count. And I'm really kind of involved in all things in terms of mainly the education and developing each of the courses that we bring to you. We try to bring cutting edge courses to you. I'm also involved in what's called the breakout sessions committee selection, where we decide what was going to be the best highlighted topics for that year. We also have poster submissions and paper submissions. And just a little background on that, the paper and poster submission is open right now if anyone's interested until October 1st. And we highlight
Aaron,
just
how would somebody submit to that if they're interested? Do they just go to the GSLS
Yep. Just go
website
to
and
the
submit?
GSLS website and then follow the instructions there for submission.
And I understand
Um,
too, Karen, you can submit case reports or actual research as well, correct?
yeah, so we want everything for everyone, right? We don't want to just silo it into clinical cases. We want research. We want anything that someone would be interested in to be available to them at GSLS. So the posters have a wide range of topics, including myopia management, keratoconus, ocular surface disease, research on any of those topics. Anything that relates to specialty lenses, we want to highlight so that, you really have an understanding of what other people are doing from around the world. We
Mhm.
also have residents that submit, we have clinicians that submit, we have industry. So it's a really wide range of topics. And it's a great opportunity to, understand where our industry is going, presently with as it relates to specialty lenses.
So Karen, you know, I've been there and I go there every year because I'm passionate about this and realizing we're just trying to, as anterior segment specialty lens fitters, we're always trying to just see what the edge is, how we can make our processes just a little bit better. So we're always kind of trying to get to that next level. Saying that, let's say, for example, somebody's just starting to really develop a passion for specialty lenses or ocular surface disease or a combination of the two. is this a conference that's more advanced than that, or are those people welcome and actually there's parts of the conference that cater to the individual that's really just starting to learn a little bit more about this area?
I think that's a great question, and we do get that quite often. You certainly don't have to be an expert fitter to come to this program. We really try to make it welcoming for everyone. One of the things that is unique is we try to cover a broad range of topics. So if you're interested in myopia management, we've got you covered. If you're interested in scleral lenses, we've got you covered. Gas permeable lenses, let's say you haven't had that education in a while. We want to make sure that we offer those courses and that everything that relates to it with respect to keratoconus, ocular surface disease, those types of things. Another thing that we offer, which is unique in my perspective, is we offer sponsored breakout sessions where the companies actually come in and are able to highlight their product. And you're getting a one-on-one tutorial with those companies about the latest and greatest with their products. And you have the opportunity to interact directly with those people that maybe you call on the phone commonly, or maybe you just read about. You can ask them questions. And the other thing that is really important, if you're interested or are already in specialty lenses, is the networking, right? Because everyone who's fitting or is interested in fitting specialty lenses and everyone that's involved or supports the industry is there. And it's just big enough where there's a lot of people, but it's just small enough where you have an opportunity to interact one-on-one and make connections with people.
I was just about to say, Karen, that's one of the things that's really cool. I love the way that the general sessions kind of bring everybody together. So they're hearing kind of one directive in terms of the education. But then you have the opportunity for the breakout sessions, which are essentially different tracks at various times throughout the day, where you can actually go to more specialized areas or regions. And what you described as the industry supported breakouts, those sessions where again, you're hearing from clinicians that are using these technologies on a daily basis and really not only the features of the technology, but how they're utilizing clinically is phenomenal. And you hit on probably the most important piece of this is that everybody's so approachable at Global Specialty Lens Symposium. You can literally hear directly from the individuals that are creating the technologies, that are functioning and performing the research, and that are using all of this. And there's so many places where you get to do this, receptions, the exhibit hall, in between classes. You're not overburdened with so many things that you can't get that one-on-one interaction. I would assume that that's probably a big piece to this. And as GSLS continues to grow, I think that's something that's super important to keep in mind is that one-on-one interaction. So Kieran, if somebody's interested and says, yeah, I have an awesome topic that I would love to present to GSLS, how does somebody go about doing that even?
So every year we open it up to abstract submissions for the breakout sessions, just like Academy does and up to OM's meeting sponsored by the AOA. So we open it up typically in the spring. Unfortunately, the it's closed right now for this year, but keep an eye out for that. Certainly announcements on LinkedIn and Facebook, but Contact Lens Spectrum, they're one of the primary target audience for GSLS. So anything that comes from them, we're going to have updates in Contact Lens Spectrum and also optometric management.
And then Karen, where is the conference? When is the conference? Is it at the same time every year?
Yep, well, this year it's going to be in Las Vegas again. It has historically always been in Las Vegas. Stay tuned. Who knows, we might switch it at some point. It's going to be at the Horseshoe again this year. So if you attended last year, you're familiar with that location. It's January 15th through the 19th this year. 2025. I keep saying this year. So it should be a great time. We start Wednesday night with workshops. We have 4 workshops going this year. And then we kick it off on Thursday morning. We've got a fantastic program. I'm super excited about this year's program. We've got a lot of international speakers this year, and we really are taking a little bit of a different approach to everything this year. So I think it's really going to be exciting and new, even for people that attend every single year.
That's great, Karen. Any final thoughts on the conference?
You know, I know that I'm the vice chair and I maybe have a biased approach, but I really love this conference. That's part of the reason that I love being involved in it, is because I care so much about it. Um, all I can hope is that everyone is really impressed with the quality education that they're going to get, because that's very important to me. And also that they just have feel welcome and enjoy their time there. So if for me, it's a really fun conference. I know for yourself, it's probably a very fun conference. It's one of my favorites. So I hope it becomes your listeners' favorites as well.
That's great, Karen. And if somebody wanted to register, how would they do that?
Registration is open until November 22nd. If you go to the GSLS website or Contact Lens Spectrum, you will have links on that. You could, if you follow us on LinkedIn, you can easily find the links for the registration as well.
Karen, thank you for sharing all of that. And thank you all for joining us on this episode of the OI Show, where we got the down low on GSLS. Cut! All right, Karen DeLoss. Yeah,
Ugh,
girl.
I
That was
love hate
good.
doing that stuff.
Good. That was
You
really
know,
good.
you get better at it over time, but it's like you catch yourself saying something, you're like, that's what I wanted to say. Or you're like, did I just say that like 5 times? So,
Not at all. Didn't sound repetitive at all. So let's do the
keratoconus.
so for keratoconus, let's call it so I'm just gonna fire questions at you, Karen.
Okay.
Like Karen, when do you I'm gonna ask you things like, when do you think about testing for keratoconus? Like, what's the triggers for you clinically? When do you think about a GP versus a soft lens? When do you think about a specialty soft? Stuff like that. And then you give your clinical pearls on all that.
Yeah. A couple pearls that I like to always point out is pinholing people.
Mm-hmm.
People miss that a lot, and that's like my favorite pearl to hand out. So if we can figure out a way to troubleshoot that one.
I love it. Okay. All right. So now you're a pro. We're gonna do the second one here. Okay, you ready? Yeah, I got the thumbs up. Hi, I'm Dr. Mila. Hi, I'm Dr. Mila Brujic, and today on the OI Show, we're speaking with Dr. Karen DeLoss on the keys to keratoconus. Karen DeLoss, welcome. Thank you so much for being a guest on our show. Karen, give the audience a little bit of a background on yourself, um, practice setting, education, all that good stuff.
Well, thank you so much, first and foremost, for having me. I really appreciate this opportunity. It's super fun. So I'm currently at the University of Michigan Department of Ophthalmology Kellogg Eye Center here in Ann Arbor. Prior to that, well, I've been here for about 14, 15 years now, but prior to that, I graduated from Illinois College of Optometry and then moved on down to Houston, University of Houston College of Optometry, where I completed a fellowship in cornea and contact lens with Dr. Jan Bergmanson. And I also did a clinical fellowship out in Boston at the Boston Foundation for Sight and became more knowledgeable about pros and scleral lens fitting.
Well, this is going to be so apropos to your background and your passion, because really I want to dig in a little bit to keratoconus and some of the clinical pearls. So, Karen, some of the things, we go to these conferences and we see now the patients that are identified with keratoconus. and some of the more advanced fitting processes that we have in terms of specialty lenses. But what's kind of the clinical turning point in your mind that says we need to look at this patient a little bit closer? Something's not right, and I need to further investigate to either determine whether or not this patient does have keratoconus and then what to do with them. So the first question is, what are those clinical kind of cues that say, yeah, we do need to order a topography. We do need to do other testing to figure out whether or not keratoconus is an issue in this patient?
Yeah, those are great questions because I think they get missed, or sometimes, when we're moving through clinic, we can easily dismiss things. I mean, certainly if a patient says they've had multiple glasses remakes, that's usually a trigger. You want to think about demographics, right? So, keratoconus specifically, onset is puberty, up till about 20, 25. So changing higher astigmatism, so usually above 3 would be my starting point. It can be lower than that. Oblique axes, right? And then just that when that vision is not getting crisp enough for patients is when you typically want to look at that. Also trends, right? So if you're seeing no different than myopia management, if you start seeing changes in refraction, and particularly the astigmatism, if your autorefraction, the Ks are manifesting higher and higher each visit, is certainly an indication. And then I always tell everyone, just listen to your patients, right? Because half of it is just going to be cues from what they say. So those are kind of the earlier parts and when to say it. The hard part is when, sometimes patients have one eye, it's asymmetric, right?
Yeah.
So one eye is fine and the other eye is just, off the charts. So, you know, for me, I would say the easiest thing to look at is the vision, right? If things are not matching up and the retina seems fine, that's usually when I'm going to run topography.
So Karen, are there any diagnostic tests that you have where when you've identified this, so you have suspicions, you confirm those suspicions with some type of diagnostic testing, whatever that might be, topography, anterior segment OCT, a combination of those two. Are there any diagnostics tests that you sometimes will perform to say, all right, here's what the patient's potential visual acuity is, and here's what we can potentially expect as we start moving them maybe into specialty lenses?
Well, I mean, there's a billion diagnostics, right? But, one of the easier things, don't forget about your lying fruit, right? Like a pinhole is usually my go-to for everything. So, we're taught in school to pinhole our patients, but then, we get going along and we kind of forget about these really simple things that you can do. But, and then it's great. It's a great opportunity for when, maybe you've got a diagnostic lens on your patient and things aren't, going where you thought they would go. Throw down the pinhole and see where they can get to, right? Because, some of these patients, they might have scars or other pathology that can impact things. So I love that thing. Just move it down and you're good to go.
So Karen, do you find in your, I love that tip. Do you find that in your practical experience with this, you can actually get patients to their pinhole acuity once you place the appropriate specialty lenses on?
Oh, absolutely. It's really, pinhole is just a black and white, right? You either get them to the, or, you get the vision or you don't, right? So if a patient pinholes to, let's say, 20/20 under a diagnostic lens, you've got the lens on and you put the pinhole down and they read that 20/20 line, that's an indication that you need to push a little bit harder with your overrefraction and your trial lenses to see if you can get the patient a little bit higher. For me, it's a little bit technical, but it can also distinguish between whether it's the scar or the curvature of the cone that is having an impact in the vision. It also can be a really easy diagnostic tool rather than all this fancy stuff to say, hey, I need to think about higher order aberrations or even a front surface toric. So it can be just a really simple tool, rather than running your patient to the time-consuming OCT and all the special technology that we have. Using something simple while the patient's there can be efficient use of your time and the patient's time too.
So Karen, much of the conversation with keratoconic patients is a lot of these advanced options and technologies. So is there a place for traditional soft lenses or soft toric lenses for keratoconus patients? And how do you differentiate in that cone patient who you might select for a soft lens or a soft toric lens versus those where you might go into more specialty designs, the gas permeables, the corneal GPs, the scleral lenses, the hybrids, all that kind of stuff.
Well, some of it, I mean, again, it comes down to your patient, right? So I'll use myself as an example. I have a higher astigmatism, and I'm perfectly happy not seeing that crystal clear 20/20, right? I kind of see 20/20.
Mhm.
Some of my patients are perfectly happy in a soft toric lens even. They can see 20/20 because they've just got low enough aberrations and low enough keratoconus where the soft lens, just commercial soft lenses will work for them. Typically for me, I like soft lenses if I can for newly diagnosed patients and lower keratoconus, less severe keratoconus patients. So I would say below 47 diopters is kind of my target point for soft specialty lenses. If the patient refracts to 20/25, 20/20, I will sometimes even use a soft toric lens. So that's kind of usually my ballpark area for those types of lenses. Certainly piggyback is also an option. And then, GP gas permeable, corneal gas permeables really they kind of gotten lost in the wayside lately, but it's a really good option for patients. The adaptation maybe is a little bit more difficult for patients, but you've got less solutions, they're less costly. If they break, they're easier to replace. So those are all great options for patients. So it's just a matter of picking what's going to work best for your patient and having that discussion with them, right? About, hey, I've got lots of options. I don't just have one option. I've got options. And patients, especially keratoconus patients, want to know that they have more than just one option.
So that brings me up to my next question, Karen. So you touched on this just a little bit, but you have the person in soft toric lenses. When do you start considering a rigid surface for correction of that patient? Like when do you then make the transition from soft to some form of rigid surface?
A lot of times it's the patient that's going to tell you, right? They're just going to say, doc, it no different with the glasses, right? They're going to say something just doesn't feel right, or I just don't think that I'm getting the vision that I used to.
Mm.
And so for me, I start thinking of kind of moving up the chain to gas permeable or scleral once the vision is not correctable to 20/20. My target is 20/20. Now, the patients might be completely comfortable, though, at other options. So it's a matter of having that conversation and saying, hey, I'm noticing that your vision isn't as good as it used to be. Are you interested in trying any other options? How would you like me to help you? How can I help you?
So Karen, here's a tricky one. And again, this is another kind of a decision tree point. How do you then determine, so now we kind of get your logic on going to a rigid surface, but what starts the decision tree on either the corneal GPs or essentially the smaller diameter GPs, something like a hybrid lens or a scleral lens? What's your kind of diagnostic path on that, or what's the decision tree on that?
I think you could have 20 optometrists in the room and 20 specialty lens fitters, and everyone's going to have a different answer for that. Um, again, I sound like a broken record, but talking to the patient, right? Because if the patients have tried gas permeable lenses in the past, I don't necessarily want to start there with those patients with another corneal gas permeable because they're probably not, they're just going to go into it with negativity, right? So scleral lenses are usually probably my first choice these days. for most of my patients because adaptation is a lot quicker. For patients that are, again, not post-surgical, maybe below 60 diopters around there, then gas permeable lenses are a good option. Gets trickier the steeper the keratoconus. And then certainly if a patient comes in with, 75 diopters, um, I'm going to jump straight to a scleral because it's going to be really tough to get a GP to sit on the lens, to sit on the eye correctly.
Yeah. One of the things I love about the scleral lens, and this is something that I don't think we talk about very frequently, but you actually block access to the cornea for those patients. So
Mhm.
what we think is one of the environmental triggers or risk factors that potentiates keratoconus with the rubbing, you just have a physical block there. So I really kind of enjoy that with scleral lenses as well too. Karen, this was awesome. Any final thoughts for the listeners on just kind of managing the continuum of keratoconus for these patients that require specialty lenses?
I mean, the thing I've learned over the years is that keratoconus patients are really lovely people. But the best thing you can do is engage with them and involve them in the care because that's just going to bring them together so that, the way I explain it to patients is we are going to make this decision together because they want to be involved in that decision tree as well. And I think that's really important is to bring them into that decision-making process sometimes.
I couldn't agree with you more, Karen. I actually think that that's something that I started doing a little bit later on, not super early in my career. And I don't want to say the word buy-in, but the emotional buy-in to the process is much greater when you bring them along with that decision. So I fully agree with you. Well,
Yeah.
Karen, thank you so much for being on the show. This was absolutely awesome.
Thanks for having me. I appreciate
And
it.
And thank you all for joining us for this episode of the OI Show, where we talked about the keys to keratoconus.